seated lateral rotation and bending of the thoracic spine.
Okay, today we're going to be covering the upper thoracic spine from T1 to T4, and we're going to look at both rotation and also lateral bending. In this case, I'm going to utilize left rotation, left lateral bending. As we did here before, our patient's position is going to be seated in a neutral posture. We want their legs at about 90 degrees for the most part in front of them. We want the spine in a neutral posture. Your segmental contact point for the exam, we're probably going to be using either T1 or T2. As we did with the middle and the lower thoracic spine, your segmental contact points for rotation can either be the lateral aspect of the spinous process, in this case the left side of the spinous process, or if you choose, you can use the TVP as well for rotation. Just remember in the upper thoracic spine to locate the transverse process, if that's what you choose to use. Your method is whichever spinous process that you find, for the most part. And if we're up over here, I would use Dr. Browning's method of having the patient flex forward. Look for the vertebral prominence. From there, passively extend the head. Look for the last retractable spinous. That will be C6. From there, you can palpate down to whichever one, whether it be T1 or T2. From that spinous process, we go one inner space up and lateral about an inch. So that's how you'll find your segmental contact points. Relative to these, your line of drive to create rotation, if you choose to use a spinous process, it's going to be lateral to medial, in this case from left to right. If you choose to use the transverse process, it's going to be P to A. And you'll be basically pressing on the TVP on the right-hand side in order to induce left rotation. Your doctor's position is really relative to what segmental contact point you're going to take. We always want our doctor's position to be behind our line of drive, so therefore if I choose to use the spinous process, I'm going to be more over towards the side of the patient. If I choose to use the TVP, I'm going to be a little bit more behind the patient so I can fall in P to A. As in everything else that we've done here before, we're going to look at two things. We're going to look at joint play and we're going to look at end play. For review, joint play is a passive movement that takes place between neutral and pre-tension. End play is from pre-tension and pushing in to feel the recoil or the elasticity of the tissue between pre-tension and an elastic barrier. So from here, as a matter of point, I'm going to be using the spinous process. So I've located my segmental contact point. I'm going to use my contact point is going to be my thumb. I'm going to lay my thumb on the side of the spinous process, in this case the left side. I would recommend that you lay your finger down so the base of the thumb palpates across the inner space and feels the spinous process below. Since the upper thoracic spine's motion is influenced by cervical movement, we're going to use the cervical spine to bring this joint to pre-tension. First thing that's going to look for is going to look for joint play. So taking my hand on the top of the head, I'm going to rotate the patient's head to the left. What should you be feeling for? If there's normal joint play, I should be feeling the spinous processes separate. In other words, I'll feel the spinuses, as Dr. Browning would say, wag. And I should feel the top one begin to separate before the bottom. So when performing this, you can say that either spine play, either joint play is normal. If it's less than normal, you can say that it's less than normal. If you feel the two spinuses rotate as a team together, you would technically say that your joint play is absent. I'm going to rotate the head to feel the joint play, and I'm going to bring the joint to pre-tension. How do I know the joint at pre-tension? As soon as you feel that bottom spinous begin to drift as well, you know you've taken out the slack between these two segments. Once I'm there, my indifferent hand's role is to stabilize the head at that point. From here, what I'd like to do, position my body so I can basically fall into that spinous process from lateral to medial. Now, we have a couple different methods here. One, sometimes your patient is going to be stable enough, it's usually going to be the bigger, more well-developed males, where they have the stability that you can hold a hand up here and lightly spring from lateral to medial and pick up that little give and recoil that a joint has or lacks. But you may find that on your patient, as you begin to push, they're going to have instability between the cervical spine and the torso. In other words, it'll start to flop around a little bit. Well, if that's the case with your patient, we're also going to have to stabilize the torso. Well, how do we do this? In class, we learned a couple different methods. One was Dr. Browning's method. I'm going to cup over the crown or the frontal aspect of the person's head, just like you did when you're doing the cervical scan. From here, I'm going to rotate their head as far as I can comfortably, and I'm going to hook the concavity of the clavicle with my forearm. And what I'm going to do now is I'm going to walk around the patient, both rotating their torso. The reason we have to rotate the torso is we have to bring this joint to pre-tension. I can't rotate the head far enough alone to do that. So what I do is I rotate as far as I can, and I take up the slack from below. So with my hand contact, as I walk around, as I move around the patient, I'll feel pre-tension develop in this contact. In other words, it'll move freely, and then I'll feel the back pressure. So that's how I know I have it at pre-tension. From here, I now have stabilization of this torso. I'm just going to spring lightly from lateral to medial, in this case from left to right. Another way we said this is what you can do, I can take my hand contact, in this case of my right hand, and I can use this one to feel joint play. I can rotate it just like I did in the first one. Now the only difference would be is that I can bring this joint to pre-tension by just using the octave, basically the head, because as I rotate the head and bring that joint to pre-tension, I can drop my forearm over that clavicle and I can stabilize him in this position. Why wouldn't I want to use the other hand? Well, if you use the other hand that same method, you're going to have the patient's head basically right in your armpit, which is something you probably don't want to do. So from this position here, I can either I can use a spinous process, or I can use a TVP. Just because you can see it here, this would be a good doctor's positioning to use a TVP. I position my body so once I palpate that TVP, I can spring basically from P to A. I'm in a good position. My arm is against my body. I can use my body weight to spring through that joint. If you choose to use a spinous process, I'll turn the skeleton around. It's easier to see here, otherwise I'll block the view. When using the spinous process, I want to come from lateral to medial on the left side of the spinous process. To stand here like I did for the TVP and put my arm like this doesn't put me in a big advantage. I'd have to use complete arm strength. I'm not in a good doctor's position. To get in good doctor's positioning, I'm just going to turn basically parallel with my patient so I can both stabilize them, and my body weight now can fall into that spinous process, that 1/8 of an inch, to feel the resiliency of the joint. In this case, I'll be springing on the spinous process on the left side from lateral to medial, from left to right. And that's rotation of the upper thoracic spine. Do you want to go into using a patient and doing that